It's a pleasure to be here, and my first time giving a talk here. Hopefully there'll be other opportunities
We hope so too.
meet and greet and get to know you all better. But the work that I'm going to describe today is something that I often talk with residents and fellows and medical students and graduate students. I'm happy to sort of expand that to a different group of individuals who are health professionals as well today, you know, on the front lines of providing treatment for these very difficult substance use disorders, and we're going to focus on opioid use disorder today. Used to be known as, you know, opioid dependence, or, you know, and we still use that terminology to refer to the physical dependence that individuals who chronically use opioids are. And as I'm sure you know, since about the mid-1990s, we've had a terrible epidemic increase in the non-medical use of opioid analgesic drugs that has really, in many ways, caught us off guard and dwarfed a lot of the epidemiologic statistics that we typically think about with other abused drugs. I mean, it really rivals marijuana now, and that was even before you know, a lot of the legal relaxation that we've seen with medical decriminalization of marijuana in the state. So this is a big deal in terms of the rampant use and misuse of opioids. And although I need to preface this and say that all of the work that I've done over the years is really focused more on individuals who are dealing with heroin problems. However, what I'll tell you about buprenorphine applies absolutely equally to the treatment of non-medical opioid use disorders. So you can equate them, and there have been many studies done by many of my other colleagues across the country that have looked at buprenorphine, the medication I'll speak about today, with regards to non-medical use of opioids. And when I tell this story, it's sort of a medication development story, sort of a soup to nuts, if you will. And you know, so hence the sort of graphics that take us all the way from chemistry through brain imaging to a nice survival curve that describes sort of an outcome. And so we're involved sort of, I'm not really involved in the chemistry. I wasn't trained as that, but I have a deep appreciation for people who are involved in medication development and the challenges that we face in developing novel medications for substance use disorders. We have precious few medications for treating these. We have a pretty thin toolbox, and so there's a lot of effort focused on developing new medications. Buprenorphine has been a really kind of a major success story, and the Drug Abuse Treatment Act that was passed nearly 15 years ago, in around the same time that buprenorphine received its FDA approval for treatment of opioid dependence, also enabled it to, you know, it's a controlled substance, but Schedule 3 rather than, say, methadone, which is Schedule 2. And so as part of the Drug Abuse Treatment Act, it was written in to be able to be used outside of fixed site narcotic treatment programs. And so clinicians who go through an 8-hour training course can get an X waiver on their DEA license and do this in their private offices. So this expands treatment, which is really important because most individuals who have opioid use disorder, as well as other substance use disorders, are not interested in or getting treatment for those disorders. So we need to do everything we can to make treatment as accessible as possible. The Drug Abuse Treatment Act did this, and buprenorphine is the only drug, because it is Schedule 3, that falls under this act at this time. So it has a sort of special status. Now, I need to give you a professional disclaimer. I have and continue to consult fairly closely with the company, Reckitt Benckiser Pharmaceuticals, which actually just spun off into its sort of own firm within the last half year, and in helping them to design some studies for a novel formulation of buprenorphine that's a subcutaneous depot, 1 month long acting medication. This is something that they're pursuing right now, and I actually went with their team to the FDA and talked in front of the FDA on September 30th this past year about this, and as they go into phase 3 with this new formulation. So, I've consulted also for another company, Titan Pharmaceuticals, which is trying to develop, get an FDA approval for an implantable, sort of a Norplant-like insert here. We were a site in a multi-site trial for that product. So I've, in addition to doing buprenorphine studies that have been funded by the NIH over the years, I've also had some pharmaceutical contact. And none of this work would have been done without, a team of individuals, which started with my mentors, Dr. Charles or Bob Schuster, who was the former director of the National Institute on Drug Abuse from 1986 to 92. His wife, a noted scientist in her own regard, Chris Johansson, and other colleagues in the laboratory and the University of Michigan for PET imaging that I'll describe, and for pharmacokinetic data at the University of Utah, Dave Moody. Okay, so I'm going to quickly go through some of the pharmacology and clinical aspects of buprenorphine that relate to its dose and time dependency, how these things relate to clinical responses, and how it translates into clinical practice. So to start off with, we sort of have a happy but somewhat odd family of opioid receptors. We have mu, delta, kappa receptors, as well as what used to be called an orphan or opioid receptor-like 1 receptor. It's now usually called the nociceptin receptor. And it has some structural homology with these other opioid receptors, but not as much as the 3 main ones that we know about. So buprenorphine is a partial agonist at mu-opioid receptors, which are located throughout the brain. I'll show you some nice PET images of exactly where they are located. And it also is a kappa and delta opioid receptor antagonist. So it blocks those receptors, does not produce any agonist effects. Now we know that mu, kappa, and delta receptors have functions that are well characterized in animals, especially, that relate to both supraspinal and spinal analgesia. What sort of tends to differentiate them is that the mu receptor mediates the abuse-related effects. It also mediates respiratory depression, a sort of a toxic side effect, the most medically significant thing we worry about when people take too high a dose of an opioid. Kappa receptors tend to have unique effects. When you stimulate kappa receptors, you get diuresis, and you tend to get sedation. And a bit of dysphoria, and some older data suggests perhaps some psychotic or psychomimetic type symptoms. So these various receptors produce some overlapping effects. The nociceptin receptor, in contrast, actually produces, when you think about nociception, you think about pain-inducing, as opposed to anti-nociception in animals, or analgesic effects. When you stimulate nociceptin receptors, you actually get more, more effects that are sort of opposite to those of mu receptors. So this is an interesting thing that I'll allude to in just a moment here. So this is, for those of you who know a little bit about in vitro assays, this is what's called a GtP Gammas Binding assay. This is where you basically have an intracellular effector and second messenger signaling, and this shows just across a variety of concentrations what happens when you increase the concentration of buprenorphine, and what happens at mu receptors. This is its partial agonist effect. This is what kappa receptors are in the, right here. Delta receptors are here. You basically get no agonist effect. That's why they're antagonists. And then you see this rightward shift in the curve for the nociceptin receptor stimulation. So What this means, take-home message, is that buprenorphine is much more potent and at these mu receptors than it is at nociceptin receptors. And at the concentrations examined, and given I think it's like at least a 3 log unit shift, so it's at least 1,000 times less potent at nociceptin receptors as it is at mu receptors. This probably means that buprenorphine's actions at nociceptin receptors don't have a meaningful clinical effect within the dose range that we treat individuals. So it's been a little bit controversial, but certainly of preclinical interest in terms of that research. Well, when we give opioids chronically, or many opioids chronically, we can see things like tolerance, okay? Well, there's a certain neurobiology that underlies the development of tolerance and dependence. Many opioid alkaloids, although interestingly not morphine, can cause internalization of receptors, or what we call endocytosis, where they're stored in intracellular vesicles. And this can happen fairly rapidly. It's not correlated with the drug's potency to activate the receptors. It could be related to tolerance development. And a couple of studies, one using flow cytometry up here and the other using ELISA assays below, have shown that when you treat with different opioids at saturating concentrations, that buprenorphine, shown with the red arrows here, really doesn't produce hardly any receptor internalization. And there's your morphine, again, similar, to buprenorphine. However, a lot of other drugs that are known to be abused, things like fentanyl, methadone, and so forth, have the characteristic of inducing this receptor internalization. So we don't really have a great grasp as to why this is and the heterogeneity among the opioids, but this is consistent with buprenorphine's relative safety profile, that we really don't see much tolerance development to it with chronic treatment. Likewise, buprenorphine does not stimulate phosphorylation of mu receptors, as shown here in this gel assay, relative to other potent opioids, including etorphine and sufentanil. Just to show you basically that it's got some different characteristics. So it's a partial agonist, whereas a lot of opioid analgesics are full agonists. The neurobiology sort of supports its clinical profile. So what are the clinical consequences of this profile? So one thing that we encounter when we induct somebody or titrate somebody onto buprenorphine clinically is that it has this unusual characteristic where you have to be real careful the first dose that you give, because it's a partial agonist and it's being used to treat an individual who is physically dependent on opioids. That means that the person, if somebody's on heroin, or if they're, taking, Dilaudid, or if they're taking OxyContin, whatever, hydrocodone, these individuals are going to have some of their receptors occupied, and these are full agonists. Buprenorphine, when introduced, is a partial agonist, and if somebody has recently had an opioid agonist and you give them buprenorphine the first time, you can actually, in layman's terms, pull the rug out from under them. Okay? You're abruptly lowering the level of agonist stimulation because now you've got a partial agonist. Furthermore, buprenorphine has much higher affinity, Ki and Kd values, for the mu opioid receptor than do those other opioid analgesics. So it displaces those other analgesics, and then you've got less stimulation all of a sudden. What do you think happens? People are not happy campers. They're uncomfortable. They go into withdrawal abruptly. Okay? So what this means is, and people may be on different, regimens. If they're abusing opioids, if they're getting treated with opioids legitimately for chronic pain, if they're in a methadone program and you want to switch them over maybe transfer them to buprenorphine. And we published a study 11 years ago, or 12 years ago, in which we tried to go from 60 milligrams of methadone maintenance over to 8 milligrams of buprenorphine, which is an average clinical dose. And we actually dropped the dose of methadone acutely one day before we flipped them over to buprenorphine, and their withdrawal scores spiked really high overnight. And once we got past that 24-hour period and continued dosing them with buprenorphine, they were okay. That's consistent with other literature, and what we have learned from many clinical studies and our own experience is that when you are first putting somebody on a buprenorphine clinically, you really need to taper them and really just kind of let them be abstinent from their other opioids temporarily, such that they're in mild withdrawal. And at that point, a partial agonist like buprenorphine can then actually suppress that mild withdrawal, and then you're off to the races. You should have no problems after that first day of dosing, because then buprenorphine develops its own agonist properties, although at a slightly lower maximal level. So the advantage of a partial agonist is that it's got a good safety profile. You can ramp up the dose of buprenorphine, go really high. People tend not to die from taking buprenorphine alone. There's just, I mean, there's a lot of phase 4 or post-marketing surveillance going on with buprenorphine now across the world, which the company agreed to do, with various regulatory agencies to continue to monitor its safety. And what we know, going way back to Europe and when buprenorphine was first introduced onto the market there, is that buprenorphine in combination with alcohol or sedative drugs can be highly toxic. People can die because you get additive respiratory depression. But buprenorphine alone, if a person were to take a really high dose, they probably, for the most part, are going to tend to sleep a really long time. But it's not probably going to be toxic in most individuals. There's probably less than a handful of cases that I've heard about where that's happened. So quite unusual. There could have been a genetic predisposition, different, a slow metabolizer or whatever. So because, though, of the partial agonist profile, that means that somebody with a very high level of physical dependence on opioids might not get satisfactory pharmacological substitution if you put them on buprenorphine. So for somebody who's severely dependent, buprenorphine is probably not the best choice as a maintenance agent for the treatment of opioid use disorder. A full agonist like methadone is probably better. There have been a couple of trials that I've seen several years ago, I think from Europe, that have tried to sort of do an adaptive dosing strategy where you might, let's say you might prefer to start them on buprenorphine because it's got a slightly better safety profile, but if they are unresponsive, that is, if they don't stop using opioids, illegally, then you might need to then cross them over to a full agonist like methadone. And you can do that successfully without worrying about withdrawal. It's only when you're going in the direction of transitioning from another opioid to buprenorphine. So it's an asymmetrical transition effect. Again, I mentioned its affinity for mu-opiate receptors earlier. This means that it's really sticky there. It doesn't dissociate as rapidly. And that means it tends to have a longer duration of agonist substitution, suppression of withdrawal, and blockade if somebody tries to use opioids on top of it. So it can produce an attenuation of the opioid agonist effects if somebody tries to use morphine or oxy or hydrocodone. It's a deterrent, and that's what it's designed for. It's also got a fairly slow pharmacokinetic profile, so when you start to taper the dose, it actually has its own sort of natural taper associated with it. So because the drug hangs near the receptor, and it has a wide biodistribution, it's highly lipophilic, so it hangs around for a while. And that means as I say to patients sometimes, it provides an easier landing when you're trying to detox from opioids than other methods, like going cold turkey or using methadone. And so it's got a pretty good record for detoxification, dose tapering. And so, you know, in general, the longer you taper the dose, you know, the better the outcomes. So we, back in the late 1990s, we were collaborating with the University of Michigan on a center grant there. And we were trying to test what at that time, I guess, was really clinical lore. That, you know, as you increase the dose of a medication, you occupy more brain receptors at its molecular target, here, the mu opiate receptor with regard to buprenorphine. And that should correlate somewhat positively or monotonically with its clinical outcomes. Now, in the psychiatric field, at that time, relatively little had been done. There had been some work on antipsychotic medications. If you occupy the dopamine D2 receptor striatally, you know, you get relief of antipsychotic symptoms up to a point where, like, if you're at 80% occupancy of the D2 receptors, then you start to get extrapyramidal effects. Similarly, with SSRI treatment for depression, you know, there the molecular target is what? The serotonin transporter. So if you occupy, you know, maybe 2/3 or 3/4 of the serotonin transporter in key brain regions, then you get pretty good clinical outcomes. So you're sort of dosing to effect. Now, of course, you don't do that in clinical practice, but we were trying to get some mechanistic knowledge, and it had only been done really with those two kinds of psychiatric conditions. This principle had never been tested in the field of substance use disorders. So we were kind of the first kids in the world to look at this. And the great thing about it is that we had some nice tools at our disposal to do it. And so we were really looking at, you know, the ability of buprenorphine to produce, you know, favorable clinical outcomes. And the way we went about this strategically in two separate studies over time. And we were really looking at the clinical consequences of variations in mu receptor binding. So how do you induce mu receptor binding? Well, you can do it in two ways, or at least we did it in two ways. In a first study, we varied the maintenance dose of buprenorphine across different weeks within the same individual. In the second study, we initially maintained everybody on the same dose, and then under double-blind conditions, we substituted placebos, and we basically had a washout of buprenorphine. And so we had basically a time since buprenorphine effect, and we tracked clinical symptoms over that course. And so I'll tell you about these studies. So in both studies, we had a common set of methods. And I'll describe specifically in the next slide how we measured the availability of mu receptors. The availability is a term which really reflects the ratio of Bmax over Kd, the concentration over the affinity. But we can't directly measure receptor affinity in vivo in humans without extraordinary procedures. So receptor availability is considered to be a more conservative term when we interpret. So, but in general, availability is inversely proportional to occupancy. So the more receptors you occupy, the fewer spare receptors are available to bind with an agonist or any agent. We measured pharmacokinetics. We took serial blood draws from these, and these were heroin-dependent individuals who were studied under inpatient conditions. And we did plasma concentrations of both buprenorphine and its primary metabolite, norbuprenorphine. And we did this over a 24-hour period, and we also took blood draws prior to each brain scan. And then we looked at questionnaire-based symptomatology of both agonist symptoms and withdrawal symptoms. So you're getting an agonist effect when more drug is on board, more buprenorphine is on board. Are you getting less of an agonist effect and perhaps more withdrawal symptoms when less medication is on board? And this is a really important point. We were testing directly the blockade effect, this abuse deterrent effect of buprenorphine. Now, when you do that, you actually challenge somebody with an opioid. we give an injection of Dilaudid that would probably put any of us here in the emergency room. But these individuals are tolerant, and they can take it. And we've done lots of studies with these doses, so we've kind of vetted all the safety of it. But it's a very unusual thing. People are not used to thinking about this. And so this introduces some interesting ethical constraints, as well as safety concerns, right? You don't give an injection of an opioid to somebody who's seeking treatment, right? That doesn't compute, okay? So we never do these kinds of studies with people who are seeking treatment, okay? Does everybody get that? Okay, so I don't want you to think that we're really trying to get in the way of somebody trying to get better. So none of these people, and when we advertise, we say this is not a treatment study. They call us up in response to the ad. We repeat, this is not a treatment study, and we go through a structured interview. Are you still interested? When they come in to sign the consent form to be screened, not even just to get into the study, we repeat, are you interested in treatment? At any stage, the person can, if they say, yes, I'm interested in treatment, fine. We won't put you in the study, we'll refer you for treatment. Okay, and then finally when they sign the consent form, it tells them again, this is not a treatment study. So we really go to extraordinary lengths, to make sure that people aren't motivated. Even so, people, using some other methods that we've published, they actually are ambivalent. But we try our best to go about this in a proper way. So, here's the guts of the brain imaging in relatively understandable terms, I hope. What we do is we use positron emission tomography, PET, and a special radio tracer, carbon-11 carfentanil. Who's heard of fentanyl? Right? Fentanyl has lots of chemical cousins. Remifentanil is the absolute shortest acting opiate out there. It has like a bullet onset, and if you put it in an infusion, and then if you're an anesthesiologist and you turn it off, it can be gone within minutes. That's how fast it is. And then other fentanyl-like agents, sufentanil, alfentanil, fentanyl, carfentanil is in the same class, and it's got really great kinetic properties as a PET tracer, and it's like all the fentanyls, it's highly selective for mu receptors relative to other opioid receptor subtypes. It's got great affinity, and is given again at sub-pharmacological doses, tracer doses that don't in themselves produce an effect. And the way in which so really carfentanil is like another opiate drug. It is an opiate, and it's actually used as a large animal anesthetic. I once saw a study, it was used to anesthetize wildebeest out in the Arctic or something like that.
Mark, is it okay if we ask a question on?
Yeah, sure.
So I'm just curious, what's your source on that? Is that an NIH-provided product?
No, so this is done at University of Michigan. They've got like one of the best teams in the world. The guy collaborate over there is the associate chair for psychiatry now, John Carzubieta, and he's one of the world's experts in this. They have all the radiosynthesis machinery there on the U of M campus, and they cook it up.
Wow.
And they put it through pneumatic tubes, and it goes right from their cyclotron to the PET center.
Amazing.
So it's manufactured on demand. So when the subject shows up, they do the synthesis, and it's there because as a short-acting tracer, you get radioactive decay. So it's very time sensitive. So they've worked that out, and they've used this tracer in studies with lots of
the molecule itself. I mean, I hear you saying they're doing the tagging.
Yeah.
But do they synthesize the molecule itself as well, or what's your source on? I'm still confused there.
Well, no, they start with the carfentanil, and then they tag it, and so they're manufacturing it. It's a synthetic, so.
Okay. So they're synthesizing the molecule locally.
Yeah.
Okay,
Yeah.
very interesting,
Yeah.
impressive.
Yeah, so, here at Wayne State, like over at Children's Pet Center, there's only like a handful of tracers, and the development and use of these tracers is highly context dependent. You've got to have like a critical mass of investigators who are interested in a particular radio tracer to really make it happen. So, here at Wayne, we don't have carfentanil, so that's why we have to go down the road to them. So this has been used by Dr. Zubieta to look at endogenous opiate release in terms of the placebo effect, to look at in pain patients, and I've collaborated with him on some other grants as well about this. So anyway, this brain imaging method really assesses the degree to which buprenorphine, which is already present in the brain because we're dosing it, we're experimentally manipulating the dose and the time since dose when they go into the scanner. And so we really have an in vivo competitive binding assay. Buprenorphine is on board in some known dose, concentration, and then we're injecting intravenously the tracer, which then crosses the blood-brain barrier, goes into the brain. The PET scanner, it's a big brain camera, right? So it's getting images of the radioactivity accounts that are being emitted by the tracer decay, and those are picked up and recorded in a standardized manner, quantified, and then we get the pretty pictures that I'll show you. So again, buprenorphine occupancy of receptors is the opposite of mu receptor availability. The technical term is non-displaceable binding potential.
Do they have to drop urines to show they don't have any other opiates on board?
Yeah, so everybody gets admitted to the inpatient unit that we contract with, and so in these studies what we did is I'm going to answer your question in, I think, 2 slides, so hold that thought. So just a quick review again. These are male and female heroin-dependent volunteers. I told you they're not seeking treatment. They're willing to take bupe daily, live on an inpatient unit. They're comprehensively screened, both medically and psychiatrically. And we exclude the majority of individuals who call us up, okay, because they have lots of comorbidities. You know, they've got high blood pressure, they've got elevated liver enzymes, abnormal EKG, high blood pressure. They may have high blood sugar. They may have depression, anxiety disorder. They may be cocaine dependent, okay? We go through all of that and more. And so we actually get a fairly rarefied sample, which I describe as they're healthy despite their heroin use, okay? Okay, so you can certainly question, you know, are these representative people? Well, probably not, but we get very orderly data. And it's because we've excluded those other confounding variables, we get a cleaner interpretation. And of course they have to have adequate IV access because we're injecting a tracer intravenously and we're taking out blood samples at a different time for plasma pharmacokinetics.